All right, everybody. Well, welcome to the Division of Cardiology Heart Failure Citywide Rounds on heart failure and putting it all together with cases. This is the third in the series, and I welcome you here. We are recording this session, and it will be posted to the Libin website. So before I start, I'd like to welcome you to, as is part of the University of Calgary, and I'd like to acknowledge the traditional treaties of the people of Treaty 7 in Southern Alberta, which includes the Blackfoot Confederacy, as well as the Tsuut'ina First Nation and the Stoney Nakoda. Calgary is also home to the Métis Nation of Alberta Region 3. Just give me 2 seconds. Now, I'd also like to thank our sponsors, AstraZeneca, Bayer, BI Lilly, Novartis, and Servier. And just some housekeeping. I'd like you to make sure you keep mute unless you have specifically oral questions. And please put your questions into the chat window and we'll try to address them between cases. Our presenters have one or sometimes two cases, and we'll try to ask some of the questions between cases. If you specifically have a question you want as an oral question, just type into the chat window, I have an oral question, and we can get you to come off mute. And I think, Sheena, we still might have evaluations at the end, but we'll clarify that at the end. In terms of the the presentations, in terms of what our goals are, we're going to talk about cluster schema for using the 4 foundational medications in heart failure, highlight the need for and importance of a safety visit in heart failure, review hyperkalemia in heart failure, and then optimizing heart failure therapy through cardiac pacing, talk about diagnosing obesity-related heart failure, which is less recognized, review the management of refractory right-sided heart failure, and talk about sleep disordered breathing if we can. Through all of these things, we will try to get through them. If this is the agenda, we hope to be done by 8:30, earlier if we can. So it will be a couple of hours. I'd like to introduce you to our speakers all at once at the beginning in essentially the order of presentation. So I'll start off with May Sumrain. She had her Bachelor of Sciences in Neuroscience in 2002 at the University of Alberta, and then Bachelor of Science of Nursing 2005 at the University of Toronto, and then was a CVICU nurse for 7 years and a regional coordinator of the Alberta Stroke Program. In 2013, she became an NP and had her master's in nursing and worked as an NP on the cardiac surgical ward for 6 years at the Foothills Hospital. She now is currently working at Total Cardiology as an NP in the Heart Failure Continuity Program, which she'll talk about. Next, we have Dr. Nicole Sharma, who did his internal medicine, cardiology, and advanced heart failure and transplantation at the Universities of Saskatchewan, Alberta, and Calgary. He has a master's in public health, and he's currently the Rocky View Cardiology site lead and the medical director of the Rocky View Heart Function Clinic. He works towards improving heart failure care in Southern Alberta through the use of order sets, pathways, and knowledge translation. Third, we have Dr. Brennan Ballantyne, who did his cardiology at Western and his EP or electrophysiology at the University of Calgary in just last year. And he's now doing his advanced heart failure training at the University of Calgary. And he also has an interest in remote monitoring CIEDs, select cardiomyopathies with significant arrhythmia components, such as patients with sarcoid, ARVC, and HCM. Our final 2 presenters, we have Dr. Kristin Lyons, who did her undergrad at McGill and cardiology at U of A, and did advanced heart failure at the University of California, Los Angeles, and her echo at the University of Calgary. She's actually quite active in the Canadian Cardiovascular Congress, and we welcome her to present a little bit on the later side. And then Omid Kiamanesh, who did his cardiology at the UBC and advanced heart failure at University of Toronto, and his echocardiography at the University of Calgary. He's also quite involved in many national initiatives. So I'm going to stop presenting, and I'm going to bring it to May, who's going to talk about the foundational therapies.
You got my screen?
That is a good question.
Oh, no, not yet. Hang on.
I don't see it.
Now.
Yep, that's good.
Okay, good evening, everyone. It's a pleasure and a privilege to be asked to speak tonight, along with this panel of highly esteemed colleagues. I have no disclosures or conflict of interest tonight. I do have a special thank you to Jonathan Howlett, who not only has been a wonderful mentor to me in the last 10 months, but also gave me permission to use 3 of his slides in order to provide context to my first case. We have a great evening ahead, amazing speakers and cases to come, so let's jump right in. My objectives for this evening are to highlight the Heart Failure Continuity Clinic, especially for those who are unfamiliar with it. My first case presentation is going to demonstrate one of the several examples where I've been able to use the cluster scheme of what we call, or for what we call, an ideal patient. And my second case presentation is going to highlight the need and importance of a heart failure safety visit. And lastly, I really want to raise awareness about some challenges and gaps that patients face upon discharge from hospital. This was very eye-opening to me and humbling to me this past year when my career transitioned to the outpatient world after 16 years in acute care. So a quick recap for anyone tonight who isn't yet familiar with the Heart Failure Continuity Clinic. Jonathan Howlett is the medical director, and I am the NP that operates it. The clinic is actually part of the Heart Failure Pathway Initiative that's under the Cardiovascular Health and Strokes SCN. It's meant to support patients as they move from hospital towards community and primary care. We know that patients with heart failure and COPD have the highest rate of readmission to hospital in Alberta. And statistics show that our 30-day follow-up of heart failure patients post-hospital discharge is quite good. It's well over 70%. However, at least 50% of the approximately 2,200 heart failure patients in Alberta cannot be seen within the first 7 days by their GP. So when patients are discharged from hospital with an exacerbation of their disease, the evidence shows that follow-up with a GP within 7 days prevents readmission. So essentially, this clinic is geared towards filling a gap in care for those patients who cannot be seen by their GP within a week. We know that seeing these patients early will result in better outcomes. So once the patients are discharged from hospital or from an ED, they can be referred to see me in clinic. I usually see the patient once and ensure they are clinically stable. I usually take the opportunity as well to optimize their therapy if possible. An important part of what I do is to ensure that they have follow-up, whether with a cardiologist or a cardiac function clinic, in addition to their GP. The clinic does not follow people longitudinally. That's important to know, but I always do follow up if I initiate any medications, and I make sure they're tolerating the therapy and that their blood work is stable. I often can do this by phone. And lastly, I am located inside Total Cardiology Rehab at the Repsol Center. So this is the main reference for my first case presentation. You may recognize the names of these 3 very intelligent gentlemen. In the paper, the authors propose a novel framework for initiating and titrating combination medical therapy characterized by therapeutic class, and they're placed in 2 therapeutic groups: foundational therapy and personalized therapy. If you have not read this paper, I highly recommend that you do. Essentially, it states that foundational therapy should be used in all patients with HFrEF, as we know from the current heart failure guidelines, because these medications confer rapid and robust benefits in terms of mortality and morbidity. We know they also work in an additive fashion. Personalized therapy should be just that. Certain subgroups of patients may benefit from the adjuncts. My first case is only going to highlight the foundational therapies. I will not be speaking about personalized therapy tonight. So Mr. Rodeo is a 49-year-old male who was healthy at baseline. He was at Stampede last year on the evening of July the 10th. He was enjoying himself, having an alcohol beverage, when he started to experience chest pain that radiated to his shoulders. He presented to Sheldon Schumer, and he unfortunately left without being seen. He was told by a nurse that she thought his symptoms could be anxiety. On July the 14th, he started to experience some new discomfort, only with deep inspiration that was more characteristic of pleuritic pain. He presented to the Foothills Emergency Department, and his ECG unfortunately showed Q waves in the inferior leads. His angio showed diffuse disease, and his echo showed a moderate LV dysfunction of an EF of 40 to 45%. His imaging also noted a small inferior wall pseudoaneurysm suspected, but with no high-risk features. So the decision was made to medically manage him. He went on to the cardiac rehab program, and during the program on September 20th, he presented again to FMC via EMS with more chest discomfort, and follow-up imaging had found interval deterioration of his LV function, which now was severe with an EF of 29% and the rapid development of a large LV aneurysm. So he underwent urgent surgical repair and he was referred to the HFCC. So in clinic, he had a very good blood pressure. He had a heart rate in the 80s. His weight was 86.9. Everybody gets weighed at an in-person clinic visit. His ECG did still demonstrate QAs in the inferior leads. His physical exam was unremarkable. He was euvolemic, and his most recent labs looked great, actually stable electrolytes and good renal function. These were the medications that he came to clinic on. Definitely on good cardiac risk reduction therapy, but not optimal for his heart function. So let's refer back to the publication about a novel approach to heart failure management. The authors identify that patients who typically have all these conditions present can generally tolerate 3 medication changes in one visit, with a low rate of side effects. When all the conditions are present, we refer to them as an ideal patient. The key is that you can only make 1 titration or initiation from each of these 3 HFrEF therapy clusters, which are grouped together based on similar mechanisms or effects. You can pick 1 preferred medication from each cluster and initiate or titrate them simultaneously. This cluster scheme was all presented in parts 1 and 2 of this heart failure series. If you guys missed either or both, I highly encourage you to watch them on the Libin YouTube channel. In speaking with so many different clinicians, I've really come to appreciate that there are so many different methods to approaching the management of heart failure. And if I were to poll all of you tonight, I'm sure there would be numerous different approaches. There would also be very different thresholds for comfort of what you do in a single visit. So let's go to what the evidence says. The evidence says that each of the 4 foundational therapies reduce mortality and morbidity quickly, within about a month, guys. They act fast. So the goal is to treat aggressively and get them on all 4 agents as quickly as possible. Another thing to keep in mind is that the quicker you get them on the drugs that work, the more they're going to tolerate it. And remember that they work in an additive fashion. These are the things that are always on my mind in clinic at every visit. I essentially ask myself, what's the most I can safely accomplish in this one visit? So let's look back at our parameters with Mr. Rodeo. He very clearly meets all the parameters for an ideal patient. He's got a blood pressure greater than 110, his heart rate's greater than 70, he's not dry, his potassium is less than 5, and his eGFR is greater than 30. So according to the cluster scheme, this qualifies him for either a titration or initiation of 1 medication from each of the clusters. So let's look back at his meds and focus on the 4 foundational therapies. In terms of what can be initiated, he's already on an ACE and a beta blocker, so there's still an MRA and an SGLT2 inhibitor to add on. And in terms of possible titrations, well, his beta blocker could be increased for better heart rate control. And we have the option to change his ACE to an ARNI as a superior option. So that's 4 possible changes now, but we have 3 to make. We have to consider the category of each therapy as well. For example, we would not initiate the MRA and change the ACE to an ARNI in the same visit because they're from the same cluster. So ultimately, I did proceed with 3 changes that visit. I changed the ACE to an ARNI, I initiated an SGLT2, and I titrated his beta blocker, 1 change from each cluster. He had private insurance, which to me is like a gift in clinic. However, as you probably all know by now, that as of this week, Blue Cross will cover DAPA in patients without diabetes. Hooray! I gave him his prescriptions and we scheduled a follow-up visit about 10 days later. So on his follow-up visit, he tells me about a syncopal episode he had that morning. He had a hot shower and shortly after stepping out, he fainted. It was very typical of a vasovagal episode. We did orthostatic vitals on him and he did show a postural drop. And he was also dry on exam with a low JVP. So I did provide some education surrounding the diuretic effects of his ARNI and an SGLT2. I urged him to stay better hydrated. I made no changes that day. I ordered blood work and scheduled a follow-up 1 week later. So at this appointment, he was euvolemic again on exam and had no postural drop with his blood pressure. And his heart rate is better controlled now at 73 versus in the 80s. So his labs do show a 30% jump in creatinine, which is what we would expect to see when initiating an SGLT2. It was probably also exacerbated by his hypovolemia. So if we look at his medication list now, he's on 3 of the 4 foundational therapies, and his heart rate is well controlled in the low 70s. So now it's time to order the 4th foundational therapy. It's exciting, guys. I ordered Spiro along with more blood work, and I scheduled just a quick telephone follow-up. On the phone call, I let him know that his electrolytes were stable, his renal function was recovering. So I told him he could increase his MRA to a full dose of 25 milligrams daily. So at this point, he is on the highest tolerated doses of all foundational therapies, which was done in exactly 4 weeks. He was feeling great, taking 1-hour walks almost every day. He went on to do cardiac rehab shortly after. He did great in the program, and I'm happy to say that he is on all of his therapies still. So what's the moral of the story? An ideal patient is one who fulfills all the parameters I've mentioned. You can safely make up to 3 initiations or titrations, 1 from each cluster in a single clinic visit. Some important things to consider. Patients require clear instructions and education. In my experience, a lot have some dizziness upon initiation of Entresto. I coach them to monitor their blood pressure every day. If it remains stable and the dizziness is very transient, then it often resolves in a few days. And it's important that the patient understands that each medication change. I often provide written instructions so they can refer back to them. I also, every sample box that I give out, I literally write right on the box as though it were a prescription bottle to avoid confusion. Prompt follow-up is key to ensure they're tolerating therapies from a symptom and blood work standpoint. And I call it ongoing negotiation and discussions are important. Some will find it shocking that you're going to make so many changes at once. They're already overwhelmed on being, on new medications in many cases. So I always educate on the additive benefit of these medications. I assure them that it can be done safely if they're the right candidate. And I will say it does take a good rapport and trust from the patient to go about this effectively. And lastly, an important factor is the patient has to have ownership over their health. Making these changes in one visit requires that they understand their diagnosis and that they can follow instructions clearly and that they are motivated to recover. And that's all for my first case.
Great, thanks, May. That was fantastic and really does emphasize how you can get these patients in a short period of time on the 4 foundational medications. And you may not have the ideal patient, but maybe you have less ideal, you might be able to do 2 at a time. So that's really important. I didn't see any questions in the chat, but maybe I could just ask you, since he had insurance, did you think about using amplironone instead of using spironolactone as an option? I sometimes do that, particularly in private pay patients, because it is covered and less potential side effects in somebody like this. What do you think of that? Is that something that you've been doing for, obviously we see a lot of patients who are on public, but if you're on private, that might be an option as well.
That's insightful, Sandeep. I will be honest in saying no. It's maybe mostly out of habit and comfort in using spironolactone mostly, also from my hospital practice days. So I can't say that I do regularly, no, but something to consider when they have private coverage.
Yeah, and particularly in males where they may have that these other side effects, gynecomastia, et cetera. So I think that might be an option for, and as you know, in the public pay patients, if they're on spironolactone and have side effects, they are covered for amplironone. So just keep that in mind for people that you can switch them if they're having side effects to spironolactone, to amplironone when it comes to things like gynecomastia, et cetera. So it's just another option. Why don't I let you go ahead with your second case?
Okay, awesome. Thank you. Okay, so my second case of Mr. Jones. This next case is more brief. I really just want to highlight the importance of a safety visit. So this 71-year-old male with no atrial flutter, presented to Sheldon Schumier with complaints of 2 weeks of left lower quadrant abdominal pain and associated with acuteness, shortness of breath. He also endorsed shortness of breath on exertion with NYHA class 3 symptoms when he presented. His atrial flutter was found to be in an uncontrolled rate, so he was admitted. He admitted to suboptimal compliance with his DOAC and beta blocker at the time. They treated him with IV and oral metoprolol, and his troponin was found to be elevated, so they gave him high-dose ASA, and they had transferred him to Foothills. He was admitted with decompensated heart failure, and it was found to be a mixed ischemic and non-ischemic etiology. So he received a TE-guided cardioversion for his atrial flutter. He was diuresed. They started him on guideline-directed medical therapy, and he was referred to the heart failure continuity clinic. So in clinic, his vitals were stable. He was in a sinus bradycardia. His exam did show him to be a bit dry, and his labs were good, stable electrolytes, and normal renal function. So I had just finished taking his history and started on his physical assessment, and he decides to tell me of an incident he had a week prior. He spoke of an episode where he felt off and experienced what felt like a shock or mild pain to his temples that lasted about 30 seconds long, and he felt weak and fell to his knees. So I did take the time to ask him if he had seen his family doctor about this, and his literal reply to me was yes. He cleaned the wax from my ears, but I'm not sure that did much. So at this point, my radar was up that something was much more concerning, and I decided to ask him to do something very taboo during COVID times, which was to take off his mask. And sure enough, he had a facial droop. His sister was in the room, and it was a trick I learned in stroke neurology. If there is a photo ID or someone that knows them in the room, to ask. She admitted that she hadn't noticed before, but confirmed that his face indeed looked different. So I went on to do a neuro exam. Everything else was normal, but he did have ipsilateral facial numbness to his droop. So at this point, I've basically told Mr. Jones that he's likely had a stroke in the past week and that he will require a neurology consult. The next thing I did was to reconcile his meds. He was discharged on great therapy, already on all 4 foundational therapies, except he proceeds to tell me that when he got to the pharmacy to fill his prescriptions, he was told that no Blue Cross authorization was processed for any of these 3 meds that required it, and he was forced to pay full price for everything. He couldn't afford to dispense them, so he paid for the EMPA and the Doxaban, but didn't get the Entresto. So now I'm very concerned. We have a gentleman with no atrial fib. Although he was cardioverted and in sinus brady in clinic, I didn't know for certain that he wasn't paroxysmal. Also with a history of non-compliance and also not being able to afford his meds. Was he rationing the supply and not taking everything? Or was there some kind of drug interaction that was decreasing the efficacy of his DOAC? So what did the heart failure continuity clinic do to help him? First off, I told him to stop his Lasix. He was dry, plus the Entresto, Jardiance, and Spiro would continue to impart diuretic effects. I called his pharmacy. That's when they told me that all 3 forms were either missing information or missing altogether. So I resubmitted all 3 forms. Fortunately, later I received confirmation that he was approved for all 3. I gave him samples of the Entresto and the Jardiance to bridge the waiting time of Blue Cross. I called his family doctor, who was shocked, to facilitate pardon me. Sorry, guys. Whoops. I called his family doctor to facilitate an urgent neuro consult. The patient was thankfully seen a little later that month. And he had a head CT and a brain MRI of his brain that confirmed multiple small infarcts. And as it turned out, there was a serious drug interaction with his phenytoin that he was taking for a previous seizure disorder. So the neurologist changed him over to lamotrigine. So given his history of medication non-compliance, I felt that he needed ongoing education and monitoring. So I also referred him to a cardiac function clinic, as well as cardiac rehab for another layer of support and monitoring. And he did go on to do the program for 12 weeks. So the moral of this story, folks, this is one of many stories of serious near misses in clinic. A lot can happen and go wrong after a hospital discharge. The next lesson is trust your clinical instinct. These are complex patients with many comorbidities and high risk for complications. If you sense there's a bigger problem, it's usually worth digging deeper. And the third reminder is of drug interactions. Sometimes a patient can be on all the right therapies, but not receiving the full therapeutic effect due to interactions, or worse, there could be harm as a result. These were all caught with a heart failure safety visit, and I've seen time and time again that a focused heart failure follow-up, even if a patient has already seen their GP, is never in vain. I quickly want to identify 3 gaps that consistently come up when I see patients. The first is follow-up with cardiology. This is especially for patients who are not referred to a cardiac function clinic. Whether they're discharged from cardiology or from cardiac surgery, patients usually don't realize that they need to contact the cardiologist to book follow-up. This is an easy way for a patient to fall through the cracks, something worth reinforcing before a patient goes home. The second issue is with Blue Cross forms. I know the inpatient pharmacists are amazing, and forms are often sent out once that they know the patient's going to be on the medication. But depending on the timing of when the med is initiated or the length of the hospital stay, many arrive to pharmacy to find that the authorization has not been processed. I've had several patients simply not fill the prescription because of the high cost. So if you think this may be the case for one of your patients, it's worth sending them to the heart failure continuity clinic. I can at least bridge the waiting time with samples. And the last thing I want to mention is that prescriptions printed from Sunrise Clinical Manager are confusing for some patients. I've encountered this multiple times. The sheets printed look nothing like traditional prescriptions. And I've had numerous patients arrive to clinic with papers from their discharge, and I'll see them amidst their pile of papers, and they think it's a medication list. So unless it's been faxed on their behalf, patients can be confused by it. And I've had to send a number of patients directly to the pharmacy after seeing me to fill their prescriptions. I'd like to say a special thank you to everyone listed here. It honestly takes a village to provide quality multidisciplinary care to heart failure patients. Shout out to the nurses from TCR who are online tonight. And thank you everyone for your attention.
Well, thank you, May. That was great. And, you know, forms are the bane of our existence, the Blue Cross forms. And certainly our pharmacists do a great job at the hospital. I agree with you 100% there. I think it is important that the drug-drug interactions get sorted out. We often rely on our pharmacists at the hospital and our pharmacists in the community to help us with those. Kristin did have a question in regard to how do you think we should improve getting these insurance forms approved and filled out and approved? Do you think there's any better way than we currently have? What I often do is as soon as I prescribe the drug at the hospital, I actually try to get the Blue Cross form sent right away. Like literally, if it's day 2, I send it day 2.
That's the key, Sandy. I think that's the key.
Don't send it at discharge. Send it as soon as you prescribe it in hospital. And even if it's not a drug you can discharge, let's say if something changes, that's okay. They've got the Blue Cross form that's been approved. You don't prescribe it, but it's worth it if it's the other way. So I think to me, it's fill it out as soon as you can.
And honestly, I think sometimes a heads up to the patient, it's a lot of shock for them. Sometimes they will go ahead and pay for it for their well-being, but it's a shock of the cost. So even if they know, by the way, you might arrive and find this not covered, and if that's the case, just dispense 1 month and the authorization should come through, or even just 2 weeks.
Yeah, and I think Omid made a very good point. For those with outpatient EMRs, the Blue Cross forms are fully in there, like in our EMR. It's in there. It takes literally 2 seconds to fill it out. I sometimes will, like I usually do the prescription and the Blue Cross form exactly the same time. And I actually fax them myself from the office so that it's like, it's gone the second I've given the prescription. And I think most EMRs are like that. It's obviously not an SEM. I don't know about Epic in terms of it's in there. I probably should know, but I don't. So hopefully it'll be in Connect Care and it'll be a little simpler. All right, May, we got to move on. So I think we have Nakul next. I think he's online. We'll get him to do his presentation next. There he is.
Okay, in the interest of time, I will just go ahead and jump into it because I know I have 2 other speakers after me. So I have the arduous task of trying to explain to people how to treat right-sided heart failure, how to improve diuresis, and when to consider treatment for sleep disordered breathing or when to be suspicious of it. And I will use a case that myself, Jonathan Howlett, and I believe the fellow at the time was involved with to try, and we came up, we serendipitously found out about a guy who has sleep disorder breathing while in the echo lab, and you'll see what I'm talking about very shortly. So I have no relevant disclosures in regards to this topic. The case that I'm going to present starts off a little complicated, but Mr. DS is a 65-year-old male with a known history of type A aortic dissection in 2009, surgical repair and residual thoracic aortic dilation, presented in rapid atrial fibrillation as his first presentation to us on the heart failure service. He was appropriately admitted to hospital and identified he needed to be diuresed. His echo at the time showed normal left ventricular function, mild reduction in his right ventricular function, moderate TR, and mild to moderate pulmonary hypertension. Pretty standard stuff. It was initially unclear what the precipitant was, as the patient did not describe any adverse changes to his medications, to his overall health. And so it wasn't sure if it was his if it was his atrial flutter or if it was heart failure precipitating that, but nonetheless, he was diuresed. He successfully did well. And he also, when euvolemic, underwent a cavo-tricuspid ablation for medical refractory atrial flutter and was eventually discharged. Unfortunately, as with everything, when we come to these cases, he represented 6 months later with full anasarca, edema all the way up to his belly and higher. His initial presentation suggested a non-arrhythmic cause, given the fact that he was in sinus rhythm now and had tolerated the ablative procedure. His current weight was 111.1 kilograms. Blood pressure was normal tensive, and his heart rate, as I said, was sinus rhythm and control. JVP was through the roof. Don't need to explain that when it's 10 centimeters above the sternal angle, it's clearly abnormal, bibasilar crackles, and the bottom half of his lungs were full of fluid. He came in on amiodarone, 100 milligrams a day, carvedilol, 25 BID, synthroid, and warfarin because of the history of atrial flutter. An MRI was completed at the time when he was able to actually undergo a cardiac MRI because there was concerns about constriction given the recent ablative procedure and surgery. It did show some septal flattening on inspiration, but no concrete evidence of pericardial constriction. An echo was done, which showed moderate right ventricular dysfunction this time, moderate pulmonary hypertension, and an RVSP that was increasing. There was severe TR, and without any observed left-sided abnormalities. So very interesting changes noted, particularly on the right side of the heart. Unfortunately, despite extensive imaging, the etiology of the repeat admission was unclear. So he was started on diuretics, but it became difficult to get him euvolemic during the course that I spoke of. And so what I want to talk about is 4 very simple points, and I'm going to try to do that in the next 15 minutes or less to try to give our other colleagues here some ample time to describe their case. But we're going to define when to double down on diuresis. What do the guidelines say in brief? I did present some of this on our last citywide round, so I'll go over it a bit quicker this time. What are other methods of diuresis and refractory right heart failure? So these are not evidence-based guideline type therapies. So these are dissimilar from what May talked to you about. This is sort of tricks that you can use when you're getting desperate. And how do you define success quickly? And when should you suspect sleep disordered breathing? Sorry for using the acronym. So this was shown to you once before, but it's quite easy to differentiate euvolemia versus congested. JVP is quite high, 6-minute Watt test is down, edema, hepatomegaly, chest X-ray findings, vena cava if you're going to do a quick bedside echo, and lung ultrasound, which is now becoming more common with POCUS, or just listening to the lungs and hearing for crackles. And so you want to try to catch these people at a point where they're on a downward trajectory from clinical decompensation, and you want to then be able to figure out when you need to double down or start to get them on the proper diuretic, holding or not holding some of their other goal-directed medical therapy, but then transition them to a point from the red arrow on the left to the red arrow on the right. And so this is sort of the art of medicine, and you will probably recognize that May's cases and input is generally when you're in the optimization phase. So I'm going to focus on how to actually get the fluid out, because that's sort of the question that was posed to me. And so when you think of the nephron, you think of sort of 4 different areas you can attack. One is the proximal tubule. So we're going to talk about the use of acetazolamide and SGLT2 inhibitors. You could think about other thiazide diuretics. You could think about loop diuretics, which is loop of Henle. Thiazide diuretics help inhibiting the function of the sodium potassium channel in the distal convoluting tube. And then lastly, not to forget that you have aquaporin inhibitors such as tolvaptan and other vaptans. So this is where you can then target and kind of concoct your recipe for trying to diurese someone when they become refractory, meaning that you're not able to get as much efficiency out of the loop of handling. But before getting there, no, this is really small. So I will defer to the Canadian sort of aspect, which some of you may have already seen. But in essence, you want to double the dose of your diuretic. Generally consider IV. You want to assess weight change in urine output over 24 hours. And if you're getting less than 0.5 kilogram or less than 3 liters of urine output, you want to increase your loop diuretic by 50% and possibly consider metolazone. If you're getting an appropriate change between 0.5 to 1.5 kilograms and you're getting adequate urine output, continue the course. And if your weight change is significant, you may consider reducing the diuretic to avoid other complications, such as electrolyte imbalances and or dehydration at some point. So what do you do when this doesn't work? So despite your best efforts, you fail and you fail and you fail and you fail and you fall flat on your face. And all you end up doing is increasing the creatinine, and you're not really getting any urine output. This is a common consult we see on the advanced heart failure service. And I'm sure a lot of other cardiologists and specialists see the same thing. So what are some tricks to use? So one of the tricks I use, and I use it a fair bit in the sense that once I've kind of exhausted loop diuretics, I've exhausted the use of metolazone, and I'm causing a metabolic alkalosis, I use acetazolamide 250 BID, or you can increase the dose to TID or higher if you like. But the goal is to stimulate secretion of sodium bicarbonate by turning off the ability of carbonic anhydrase. So basically, you're going to prevent bicarb from forming back into CO2 and water, and you're then going to allow sodium excretion. This unfortunately also causes some potassium wasting, but the idea is that you're going to deliver more sodium to the tubuloglomerular feedback system so that you can get rid of actually bicarbonate. And as a result, this is a very effective way to get rid of fluid. In fact, it's used with mountain sickness quite often when people develop pulmonary edema. So what are some other tricks? So this is another off-label trick, not to be confused with the fact that we're using it for heart failure with reduced ejection fraction, but I have used it in the context of individuals with elevated BNP who are right-sided heart failure. I have 3 or 4 people who actually pay for Entresto out of their pocket to have a natriuresis or diuresis that is prominent enough to keep them out of heart failure. And you can see the reason why I was confident to do this is because you could actually see a drop in the NT-proBNP, suggesting an actual diuresis or natriuresis that above and beyond the use of enalapril. And so this continues on beyond randomization. And another trick to consider, albeit it's not covered, and you're probably going to run into trouble if someone doesn't have special authorization in some way, shape, or form. The other little trick you can use is you can add SGLT2 inhibitors to the mix. Remember, they affect the proximal tubule. They can actually increase your natriuresis in the early phase, and you could see that you get not only a increased sodium excretion, but a little bit of natriuresis and some fluid excretion. So if you're having issues with refractory right or left-sided heart failure, this is another thing to throw into the mix. You can, for some of us who feel a bit more confident in using the medication outside of just HFrEF, I have used this, and that's why I think it is safe to use, not only in HFrEF, HFpEF, and right-sided heart failure, albeit you have to be careful of how you get it covered. So if you have heart failure, preserved ejection fraction, or in this case, right-sided heart failure, you want to sort of tailor your diuresis to the volume overload, and to maintain the euvolemia with the improvement of symptoms. Some tricks you can use are, if you have hypertension, consider ACE inhibitors, ARBs, reduce the afterload, nitrates to reduce preload. MRAs have some benefit noted in some patients with elevated right-sided filling pressures, particularly if they have a high RAS system or activated RAS system. Beta blockers should only be used to control heart rate or arrhythmia, such as rapid atrial fib or flutter. Acetazolamide in metabolic alkalosis. SGLT and Entresto, not indicated, but if you're desperate, why not? Lastly, the use of milrinone and phosphodiesterase or PDE5 inhibitors, such as sildenafil, could be used if you suspect significant peripheral vascular resistance. However, I would caution you that you should probably involve one of the advanced heart failure cardiologists. And then by all means, treat comorbidities. So if they've got ischemia, if they've got COPD, and I'm going to particularly talk about OSA, but you should consider treating all of these comorbidities. Unfortunately, what works for some doesn't work for others. And in this case, the patient that I presented actually went on to have a diuresis weight down to 96.4 through aggressive IV furosemide, spironolactone, nitrates, and acetazolamide. The problem was trying to transition him to oral furosemide and hope that we could keep him on there, given that we had already failed once before, not too long ago. And so taking the echocardiographic pictures from that particular case, so this was a very interesting case in the sense that me and Jonathan had great trouble in trying to maintain this patient on euvolemia just on oral diuretics. And what we noted was that when he was awake in the echo lab, he actually had a well-formed short axis, looks more like a donut for those of you who are not familiar with echo pictures. But when he was apneic, and this was the most interesting thing, the tech, myself and Jonathan let the patient sleep through the study, and you can actually see that a septum starts to deform and flattens, if anything. So what does this mean? Basically, in essence, we suspected disordered breathing, but what does this mean and how can you translate this into some therapy? You could consider overnight pulse oximetry, but if you're having significant desaturations and you're suspecting obstructive sleep apnea, you should strongly consider the use of positive airway ventilation, in addition to other heart failure therapy. And so this is what we did. We basically called pulmonary. We counseled the patient on the use of positive airway pressure ventilation. And believe it or not, we didn't see him again for a very long period of time. So why does this work? Well, the reason you should be concerned and why this works is because there's a high prevalence of sleep disordered breathing among patients with chronic heart failure. Some even quote as high as 50%. Now that could be because there's a combination of OSA and CSA at play here. Most studies looked at the use of sleep disordered breathing treatments in systolic heart failure, but there is some evidence in diastolic and right-sided heart failure. There's equal mortality regardless, but the therapies may not apply uniformly across all heart failure phenotypes. And the reason for this is because apneic spells have different effects on the right and left system, partly because you increase preload on the right, you increase afterload on the left, and the goal of the use of positive airway ventilation is to try to reduce the preload on the left, so the right, and reduce the afterload on the left. And when you don't do that, you get a whole cascade of deleterious effects, which I've labeled below. So what can you do? So like I said, when you can identify someone with sleep disordered breathing, one should strongly consider the use of what we call seroventilation or sort of adaptive seroventilation. That could be BiPAP or CPAP, depending on the metric, depending on their CO2. You should consider it for sure in systolic heart failure, but don't forget that patients with diastolic heart failure and right-sided heart failure, particularly this case, show promise not only in quality of symptoms, but potentially in mortality, but has not been proven. So I apologize, Sandeep. I was trying to also let people in. There's a few people popping up on my screen, but are there any questions before I hand the microphone off to, I'm not sure if it's Omid or Kristin.
Yeah, I think it's Dr. Ballantyne. So just hang on a second before you leave. Thank you very much. That was great. I did have a couple of questions, and for those presenters that are coming on, don't worry, we will admit people. We'll take care of that. From the standpoint of in terms of metolazone, can you talk about the timing of metolazone? Because traditionally it's always been said to take it just before you take Lasix, and I think there is some changes to that. And then I understand that adaptive cerebral breathing may not be appropriate for patients with central sleep apnea. I thought there was some discussion around, I think a study that suggested it wasn't helpful. Is that true? Maybe I remember that wrong.
Yeah, no, so yeah, go ahead, sorry.
And then there was a third question, but go ahead, you answer those questions first.
So historically, it depends on when you're going to take your distal convoluting tube inhibitors, such as thiazides or even metolazone, but it's generally suggested to take it before, only to prime the distal convoluting tube. But in essence, I would say if you have someone on a Lasix infusion, you can use it anytime. So you're right, the data is not completely clear, but there's a theoretical or thought benefit that taking it 30 minutes before may be helpful. But I have seen people forget, or you're trying to time it in the hospital and you don't quite get it early enough, and it still works. To answer the second question, you're correct. The benefit in central sleep apnea is very limited. Now, that's why they always suggest that if you think there's a combination of CSA and OSA, so I'll refer to this slide here, So if it's CSA, you should improve, you should optimize heart failure therapy. But yet, if you're still having apneic spells, reevaluate your actual conclusion if you think there's only a component of CSA. Because if you've treated the heart failure therapy and you check the BNP, the patient's euvolemic, they're feeling better, yet they're having significant apneic or hypoxic events, you should consider possibly retrialing them for possible treatment for OSA. But by and large, your statement that you said is correct. CSA, there is no, if it's truly CSA, then no, there is no benefit with seroventilation. And then I saw a few other questions. POCUS is point of care ultrasound, yes.
No, I think the next question would be, could core pulmonary hypertension treated in the same line with in terms of medications?
So I think the only thing that's going to help with core pulmonary and primary pulmonary hypertension is the use of medications for primary pulmonary hypertension, or such things as sildenafil, or you could even argue, if you have a reactive elevation in your pulmonary vascular resistance, use of milrinone. But that's why I sort of say I caution on the use of those medications, because this usually means you're in a hospital, you're being evaluated very closely. You may or may not have a Swan-Ganz catheter in. And so although I present all these great ideas, remember, these are little tricks and stuff that, or little pearls that we use on the wards to try to get fluid out. But regardless of this, these are not the therapies. There's no cookie cutter recipe for this. So for use of, I would probably refer to the last line here, but the other therapies would probably work. But if you have true core pulmonality, I think you're going to be kind of stuck using only certain medications.
Perfect, thanks. I think we'll move on. I appreciate you answering those questions. So I think the next discussant with cases is Brennan, Ballantyne. So maybe just stop sharing there, Nakul, and then we'll get moving on to Brennan. And then Omid just sent me the article on central sleep apnea. Yeah, in that situation, there was a study in New England that suggested increased mortality. So definitely should not be looking at it in central sleep apnea. Anyway, here, let's go on to Brennan. I think he's...
Hi, everybody. Hopefully you can see my screen already, and if not, please stop me. But thank you very much for having me talk this evening. It's a real pleasure. And as Dr. Agarwal introduced at the beginning, I'm Brennan. I'm the current heart failure fellow, but I'm doing a combined fellowship, and I've done a year of training in electrophysiology, and I'm actually going to finish up electrophysiology next year. So naturally, my case has to do with actually cardiac pacing and heart failure. And the intent of this is to give you some factors to consider when patients present either to the clinic or to the ward with worsening heart failure or heart failure exacerbation. And really, this is going to be a lot of the interventions, or at least some of the changes, the things that we can do with the device, is going to be the realm of the electrophysiologists and arrhythmia specialists. But I hope that after this, you'll have an idea of the kind of things that devices are capable of, the trouble that devices can cause, and at least have some familiarity in terms of, recognizing some red flags, knowing when there's some alarm bells that are ringing, and being at least able to mobilize the appropriate support, or even just order an interrogation of a patient's device to try and see if there's an issue. So I'll start with my case. I don't have any relevant disclosures, and I'll start with a 75-year-old gentleman who was admitted with acute decompensated heart failure. He had a history of ischemic cardiomyopathy. He has biventricular dysfunction with severe left ventricular ejection, left ventricular dysfunction with an EF of 25 to 30%. He also has moderate right ventricular systolic dysfunction, moderate mitral regurgitation, and no significant TR. He had a aortic valve replacement in the past, and also a CABG, and he has controlled dyslipidemia. His home medications you can see there, and we could probably have a conversation just about how to optimize this patient and how to treat him. But we're going to focus actually on some of the device issues. His history is consistent with a couple of weeks of shortness of breath on exertion, orthopnea, and PND. He said he hadn't missed any medications. He does have very mild pitting edema on exam, and his JVP was about 5 to 7 centimeters. His BMP was significantly elevated, and he was admitted to our service, treated with diuresis and nitrates to begin with, and his ACE and spironolactone were held for mild AKI and hyperkalemia. And his course in hospital was complicated initially by some hypotension and mild ongoing volume overload. And he did have significant orthopnea and dyspnea on exertion, even while he was euvolemic. He was ultimately discharged home on February 9th. And the reason I talk about this case is because we did optimize him medically as much as possible. There weren't any obvious triggers for a decompensation, but something that came up several days into his admission led to hopefully some improvement for this gentleman's quality of life and his longevity. So this is his chest X-ray. He does have some effusions and vascular distribution, but naturally I'm looking at the device here, and he does have a cardiac device with 3 leads. So this is a cardiac resynchronization therapy device, or CRT. And moving forward with the considerations for patients who have devices and also have heart failure. The first thing we kind of ask ourselves is this actually a device problem? So is the device causing the heart failure? And the 2 things that we can talk about there are pacing-induced cardiomyopathy and tricuspid regurgitation related to the actual leads from the device. The second question is the device working as it is intended to? And when we talk about that, we'll talk about cardiac resynchronization therapy, or CRT, and look at actually the percentage of biventricular pacing, which I'll explain to you, and also look at LV lead parameters, which we'll go over very briefly, but this is actually something that the arrhythmia specialists are going to look at. What other information can the device give us about the rhythm disturbances before patients are admitted to hospital, or maybe as a cause for the exacerbation? And what information can devices give us about congestion and the risks of heart failure? So patients who you're following through clinic, some of the device capabilities actually do tell us a little bit about the risks of an impending heart failure exacerbation. So first, is there a device problem? Well, the first thing I talked about was pacing-induced cardiomyopathy. So simply defined, pacing-induced cardiomyopathy is a drop in the left ventricular ejection fraction in the context of a high burden of right ventricular pacing. Why does it happen? Well, it happens the reason it happens is quite similar to why patients have an improvement with cardiac resynchronization therapy. When we pace from the right ventricle, we're generally pacing from the apex of the right ventricle, and that's very abnormal, and it's not physiologic. That's not the way the conduction system is built, and you end up having activation of the right ventricle and the left ventricle very desynchronously. And even within the right and left ventricle, the septal wall compared to the free walls are activated very desynchronously. That leads to problems with the AV valves. It leads to adverse remodeling. It leads to changes to the energy consumption of the myocardium. And it actually has cellular changes as well. So it can induce a cardiomyopathy. The estimated prevalence is very, it varies quite significantly. Some studies say 5 to 10%, and some say about 40%. Probably some of the newer studies land somewhere between 5 and 7% of patients with pacing-induced cardiomyopathy. And it obviously depends on the definition that's actually used. And the time to presentation of heart failure secondary to a pacing-induced cardiomyopathy also varies quite significantly. So some patients present early within 6 months of device implant, and sometimes it's out 2 or 3 years later. Risk factors for who is at risk of developing this type of cardiomyopathy are not well established. They're not very robust, but these are some of the at least sort of better elucidated risk factors. So patients before they're actually implanted, older patients are more at risk. Males tend to be more at risk. Patients with lower ejection fraction to begin with obviously are more at risk. Those with a history of atrial fibrillation are more at risk. And patients with wider intrinsic QRS. So the wider your QRS, the more at risk you are. The post-implant risk factors are a little bit more well established. So the RV pacing burden matters quite a bit. And the wider paced QRS also seems to be a risk factor. And RV pacing burden, based on the studies, a burden of somewhere between 20 and 40% of the time, if you're paced, that seems to be sort of the critical period or the critical area where above that burden of RV pacing, patients are more at risk of pacing-induced cardiomyopathy. And luckily, it's reversible. So if it's caught and dealt with, it's a reversible cause of cardiomyopathy and heart failure. So what can we do? Mostly there are interventions or algorithms within the device that we can change, but there are some medications that we can modify. If somebody's heart rate is very low and they don't necessarily need a very high dose of beta blockers or calcium channel blockers, then we can reduce those medications. If somebody is on ivabradine and it was added late, sort of in the order of heart failure medication optimization, and patients haven't derived a significant benefit and all it's doing is lowering the heart rate, that's also something to think about. Typically though, medication, it's hard to withdraw medications on patients with heart failure, obviously. So if you're going to be doing that or thinking about it, it would be kind of on a trial basis only. There are device algorithms that are intended to minimize the amount of ventricular pacing. So we from the electrophysiology side, we would make sure that those algorithms are on to try and minimize the amount of pacing. And finally, there are some specific interventions. So instead of pacing just the right ventricle, CRT or biventricular pacing the left and the right ventricle synchronously is a fix for this. There's also new techniques, this technique called the His bundle pacing technique, where we actually put a little lead through the tricuspid valve and right up to where the bundle of His is. And we actually engage the conduction system very early and use the patient's intrinsic conduction system to pace instead of pacing through heart muscle. And this diagram kind of shows where a traditional lead would be in the RV apex versus a His bundle lead. There are studies that show if we put the lead on the septum, not necessarily up here at the bundle of His, but somewhere along the septum, sometimes we can engage more of the native conduction system. But these studies haven't been very robust in their outcomes. The other thing that I wanted to talk about with regards to pacing-induced cardiomyopathy is we're recognizing it more and more, and it needs to be a joint decision about how we pace and what types of patients get what type of intervention. And it's nice to have a collaborative decision between the heart failure specialists and the arrhythmia specialists, because this is interesting information that shows patients who either had a CRT upgrade after already having a device, or they had a CRT to begin with. And this shows that actually CRT upgrades have a significantly higher risk of complications. So getting it right the first time is quite important. The second issue with regards to the device and the device actually causing the heart failure is tricuspid regurgitation related to a device lead. So as we all know, TR is very common. A lot of the general population have some degree of tricuspid regurgitation. Actually, over 10% of the general population has moderate to severe TR. And despite historical considerations, if you look back at the literature, isolated tricuspid regurgitation was not felt to be significant in terms of its prognosis. While even isolated TR, if it's greater than or equal to moderate, is an independent predictor of morbidity or mortality. And that's actually when you control for left ventricular function and pulmonary hypertension. So just having TR is not good. Most tricuspid regurgitation is functional. but TR related to device leads is an increasingly recognized problem. And the frequency varies. And again, like we talked about with the other cardiomyopathy, it all depends on how you define it and how hard you look for it. But the frequency varies between 7 and up to 45%, actually. Lead related TR has similar prognosis to non-related TR mechanisms. So it's even if it's related to the lead and it's causing tricuspid regurgitation, it's still bad. There are a number of mechanisms for how the actual lead can cause problems. So the lead will either directly interfere with the opening and closing of the tricuspid valve, just by being in the way of the leaflets or the subvalvular apparatus. The other things that can happen with the lead is it can actually cause adhesions or fibrosis that actually stick to the valve over time and cause problems. And then related to RV pacing, you can have right ventricular dysfunction and remodeling, and also RV pacing can cause atrial fibrillation and have right atrial remodeling, and that actually stretches the annulus out and causes essentially functional tricuspid regurgitation. So there are a number of mechanisms. The risk factors for this are if you've had an ICD compared to a pacemaker, the ICD leads are larger and they tend to create more of a reaction on the tricuspid valve. So ICDs are worse than pacemakers. Having multiple leads in the right ventricle is obviously a problem. And if you have baseline RV dysfunction or you already have an annulus that's dilated, that's a problem. And these are just some images of what we see when we look at lead-related tricuspid regurgitation. So this is a patient before they had their ICD in, and you can see that they do have some tricuspid regurgitation, but it's certainly not as bad as when after you've put the device in. And this is the way that we really should be looking at and evaluating lead-related tricuspid regurgitation is actually 3D echocardiogram. It gives the best images. So what can we do about this? Well, just like treating any type of tricuspid regurgitation, the mainstay of therapy is actually treating congestion, so diuretics, and keep patients euvolemic. I mentioned that atrial fibrillation can cause annular dilation and can lead to tricuspid regurgitation. So if they do have atrial fibrillation, then choosing a rhythm control strategy over a rate control strategy might be an option. And then trying to minimize the amount of RV pacing will be important. But in terms of interventions, most of them are pretty invasive, and we don't have a lot of robust prospective data to guide us here. So surgical repair, we know, carries a high morbidity and mortality. It's not ideal. Lead removal and repositioning, there's no prospective data, and there's a lot of problems. It's high risk as well. There are some questions about whether percutaneous approaches, things like clipping the actual valves together, the valve leaflets together with a catheter-based approach has been evaluated in some registries. And there's also a small registry actually looking at tricuspid valve replacement with a transcatheter valve, just like a TAVI in the tricuspid valve position, while a patient has a lead in place. And that seems to be feasible as well, at least in small amounts of patients. And then instead of using big leads that go down to the RV apex, pacing the conduction system may be more reasonable because we actually use smaller leads for that. So that might help. Other things would be using leadless pacemakers or actually using echo guidance while we put the pacemakers in. Next, moving on to, is the device working as it is intended to? So hopefully this will show up, which I'm seeing this. I hope everybody else is. This is an echocardiogram looking at a patient with a significant amount of dysynchrony of the left ventricle. So just to orient everybody, this is left ventricle, the left atrium. And you can see that one wall, the septal wall compared to the lateral wall, there's quite a delay in the thickening and the contraction of one wall compared to the other. This is the biggest problem with patients with specific cardiomyopathies and conduction abnormalities, and that's what we're trying to prevent with CRT. So with CRT, we put a lead into the coronary sinus that goes around the left ventricle and out laterally to the lateral aspect of the left ventricle, and it paces this area of the heart a little bit earlier. This is generally the area of the heart that's activated the latest when patients have cardiomyopathies. This is a nice image just showing before CRT and after CRT. So you can see this is an image of the left ventricle, and you can see that part of the left ventricle is taking a very long time to get activated, and part of it's getting activated early. And after you pace the left ventricle on this lateral aspect, you can kind of normalize the conduction. The trouble that you can encounter after somebody has a CRT, so this is important when you see patients in clinic with CRT or they come to the hospital with CRT, is that you need to have a lot of biventricular pacing. Both left and right, the left and right wires should be pacing almost as close to 100% as possible. And that information is really easily available through the interrogation of the device. So that's something that if you're wondering about it, you can ask the pacemaker nurses to interrogate the device as soon as these patients come in, and generally have that information available to you when you see patients in clinic as well. The things that may interfere with biventricular pacing, just so you're aware, would be sinus tachycardia, atrial arrhythmias. Lots of PVCs make it difficult for the device to pace at close to 100% pacing, and then device programming issues. The second problem that the device may not be working properly is the LV lead may not be functioning properly. And I bring up the LV lead because it's more finicky than the RV lead. So the LV lead may have actually moved, or some of the energy that actually is required to pace the heart may have changed. This is mostly an EP issue, so it's not something that really falls in the realm of the heart failure specialist, but something that is very easily rectified is if you see these patients, you always have chest X-ray, you always have ECGs, just compare old to new. And if there's significant differences in the placement of where those wires are or the look of the ECG, it may be a problem with one of the leads. Sort of wrapping things up now, what information can the device give us about rhythm disturbances prior to exacerbation? Well, we all know that the devices can detect arrhythmia, and that arrhythmia may be a trigger for heart failure exacerbation. So look through the device interrogations if you have them, or ask the device nurses, has this patient had a high burden of atrial arrhythmia before coming into hospital? Look for things like PVCs, non-sustained VT or VT or VF. I'll not talk about this in depth just in the interest of time, but there was a very interesting paper that was just published in the journal in JACC, and it does have a bit of a Canadian contingent to it. It essentially looked at a very large study of about 900 over 900 patients who had CRTs that were implanted for LV dysfunction, and it used sensor-driven data. So data that was collected by the devices about heart rate variability, about heart sounds, about fluid status, and it looked at the link between atrial fibrillation and heart failure. And as we know, atrial fibrillation can cause heart failure and vice versa. And this study showed that patients who actually had a higher burden of atrial fibrillation had more heart failure events, obviously. But what was interesting is most of the sensor acquired data suggested that heart failure actually preceded atrial fibrillation in most cases. So it kind of seems that the link is more development of heart failure and then atrial fibrillation, not the other way around. So what information can the device give us about congestion and the risk of heart failure exacerbations? This is something that's probably not readily available for any of your heart failure specialists now, or at least not regularly, but this is something that I think is probably coming to most places. It's certainly used in the US quite often, and not as much in Canada, but I think there is going to be this interaction between heart failure and arrhythmia specialists more often, especially in patients who have devices. And this is why the devices have more and more capability of actually risk stratifying patients for heart failure exacerbations. And what the devices do, they all have their proprietary algorithm and proprietary things that they look at, but basically they look at patients' activity levels. They can actually measure with an accelerometer, just like an Apple Watch can, their activity. It looks at arrhythmia burden, looks at things like heart rate variability, which will actually diminish when patients develop heart failure. It looks at their nocturnal ventricular rate. And it looks at, most of them look at this thing called Optivol, which is proprietary, but it basically looks at impedance through the lungs as a measure of congestion or how much fluid you have in your lungs. And most of these companies have the ability to then risk stratify patients as high, medium, or low risk. So this is one company's sort of algorithm, and this is another company's. This involves actually heart sounds, and it looks at respiration. So if patients have more rapid and shallow respiration, that's a risk factor as well. So wrapping up, back to our case, this is our gentleman who presented, and the questions that we asked, well, is this a device problem? This is what the device can print out for you. It can actually tell you how much CRT or biventricular pacing there is. So it's almost 100%. So it seems like that's not an issue. And pacing-induced cardiomyopathy is also not an issue because we're pacing both sides of the heart at the same time. We're not just RV pacing that we think that we know of at least. Tricuspid regurgitation is not a problem in this patient. We have their echocardiogram. What other information can the device give us about rhythm disturbances prior to the exacerbation? Well, we can actually look and see exactly what's been going on before the patient came into hospital, and there wasn't any significant detected arrhythmia. So that was off the table. What information can the device give us about congestion, the risk of heart failure exacerbations? Well, this is some of the data that the sensors can give you. This is a fluid index. So the higher these lines go and above a specific threshold, the device will actually activate an alert. So before this patient came into hospital, you can see that this Optivol, or the fluid index, was actually increasing before they came into hospital. And the thoracic impedance was decreasing, which is also consistent with fluid accumulation. And interestingly, the heart rate variability, which low is actually quite bad in this case, was not great basically since the new year, sort of consistent with developing heart failure. So is the device working as it is intended to? Well, we already said it's pacing a lot. That was one of the questions that you want to ask. And the second issue, which again, this is something that towards the end of this patient's visit, we had their device interrogated, and you don't need to know a lot of these values. I just bring it up to provide you with some at least with some evidence that this patient's threshold, so the amount of energy required to actually pace the left ventricle was about 3 volts. The patient's settings were actually 1 volt. So even though the device was thinking that it was pacing almost 100%, that was clearly not true. The left ventricular lead was actually a problem. So this left ventricular lead here was not effectively pacing, which probably contributed to this patient's heart failure exacerbation. One of the things that we could have maybe identified a little bit earlier was this a problem? And if you look back at their ECGs and compare old to new, again, you don't need to know much about what these changes mean, but it's pretty obvious that if this patient's paced all the time, a change in their ECG means that something's happened to the device, to the function of the device. And it's subtle, but you can see in lead 1, you can see in some of these inferior leads, especially V5 and V6, there are some subtle differences in the way that the QRS looks, which in retrospect actually meant that there was a problem with the LV lead. So ultimately, this patient actually had their LV lead parameters changed, their pacing was improved, and they were discharged home, and hopefully will derive some benefit from some device optimization. So with that, I will turn the floor over. And I know that this was pretty advanced and there was a lot of electrophysiology in that talk, but I just wanted to give everybody an awareness of what's out there. And I do think these things are going to be important for the heart failure specialists and general cardiologists in the future. Thank you.
Yeah, thanks, Dr. Ballantyne. I note that at the beginning there, you suggested that heart failure specialists and EPs, doc, should work well together. And I guess you'll just have to consult yourself whenever you have issues because you're going to be both heart failure and electrophysiology. But I think it is a good idea. We do need a lot more cooperation. I do know that Optivol, it was available some time ago, but I never really saw much happen. Is it now becoming more prominent? Is it being reported? Is it being sent to physicians? Because I don't really recall getting any of those reports sent to me.
I think what's happened is, at least most of the centers that I've been familiar with in Canada, a lot of the time, at least from a device perspective, on the EP side, they turn the Optival settings off. They don't want to hear about it, and they don't want to deal with it. And I think Optival, some of the original trials, has sort of left a sour taste in a lot of people's mouth because they weren't very convincing, and they weren't very significant. And the problem is probably relates to limitations in interpretation of the data, the same way that, POCUS in the wrong hands, point of care ultrasound in the wrong hands can have some problems if you don't know the limitations of the technology and the limitations of the results. But also, I think we were probably asking the wrong question early. Most of the trials were driven by longevity, all-cause mortality, sort of hard cardiovascular outcomes. And as the technology has evolved and some of the objectives have evolved, we're asking more questions about, can we keep patients out of hospital? Can we keep them in their home? Can we make them more functional using data that is already implanted or already a part of these devices? And I think for that reason, some of the remote monitoring and some of these technologies are sort of making a resurgence. Certainly some manufacturers probably have better technology than others, but I think it's going to be something that we'll see in most devices, and something that we should probably be paying attention to going forward.
Okay, thank you. And I'll let you off the hook now. And if there's more questions at the end, we can always get to them. Thanks. That was a great talk. We're going to move on to Dr. Kiamanesh, Omid. He's ready to rock and roll, so take it away.
Okay, thanks, Sandeep, and thanks, Brennan, for that. For those of you who haven't met, my name's Omid. I'm a heart failure cardiologist here. And I'm going to talk just briefly about HFpEF, or heart failure with preserved ejection fraction. I have no disclosures. So we know heart failure is bad, but I think we really need to remind ourselves of how bad it actually is, and that HFpEF outcomes are just as bad as those with HFrEF. So this is a paper that was published in the New England Journal of Medicine, and you can see here that after a diagnosis of HFpEF, the 5-year survival is only 35%, and that's the same as patients with HFrEF. And heart failure with preserved ejection fraction is actually very complicated. Part of that is because there's a number of different conditions that can lead to heart failure with preserved ejection fraction, and they involve different underlying pathologies that drive the clinical syndrome of heart failure. So don't want to belabor this, but you can have diastolic or systolic dysfunction, pulmonary hypertension, RV dysfunction remodeling, left atrial dysfunction, which we're learning more about, enhanced diastolic ventricular interdependence, vascular stiffening, microvascular dysfunction, peripheral abnormalities, and chronotropic incompetence. And the challenge there is that a patient, they don't present with the same degree of any of these findings. It can vary from case to case. But the diagnosis does not have to be that complicated. And so I'll put to you that the diagnosis of HFpEF is actually quite simple, but we have to be very clear on what it is. And so you, number one, have to have symptoms and or signs of heart failure. So you can't just have diastolic dysfunction. Heart failure is a clinical syndrome. Number two, you must have a normal ejection fraction. And we define that as an EF of greater than 50%. And then three, there must be evidence of structural, or that should say functional cardiac disease. And so that can include, a lot of this will come from the echo, but that can include left ventricular hypertrophy, left atrial dilation, diastolic dysfunction, or an elevated pulmonary artery systolic pressure in the absence of precapillary pulmonary hypertension. So left-sided heart disease causing pulmonary hypertension. And you'll note here that a BNP is not a part of the diagnostic criterion, and that's because you can have HFpEF with a normal BNP, and I'll show you an example of that. And so we've all seen tons of these cases. I just wanted to present two different types of HFpEF that I think you will see, absolutely, and you shouldn't miss. And so these are kind of the commonly seen uncommon types. which are different than just the regular diabetes and hypertension that most patients with HFpEF have. So this is a patient that was referred to me in the fall. She was a 52-year-old female that at the beginning of COVID was diagnosed with idiopathic pulmonary arterial hypertension and really quite debilitated. So she received combination targeted therapy up front and then actually was enrolled in a drug trial. And she's quite obese. The body mass index was 41. She was doing poorly in the drug trial, so they repeated the right heart catheterization and diagnosed her with significant diastolic dysfunction. So you see the numbers here, right atrial pressure of 13, mean pulmonary artery pressure of 53, the wedge was 19, and the left ventricular end diastolic pressure was greater than 23, or it was 23. And so this, we don't need to go over these numbers in detail, but just to say that she definitely had heart failure with preserved ejection fraction because it was measured invasively. And so normal is usually less than 8, our cutoff would be 12. And hers was 23. So they referred asking, why does this patient have diastolic dysfunction and HFpEF? And if she does, we would need to pull her out of the drug trial. And that would potentially be a life-threatening event. Her NT-proBNP was only 204, so that's normal. And her echocardiogram showed mild RV dilation, mild to moderate RV dysfunction, and severely elevated pulmonary pressures. And I just have a few images I'll show you here. So on the left, this is an apical 4-chamber view. And for those that read echo, you'll note that she has a very abnormal septum with abnormal sort of diastolic relaxation of the septum and a bit of a shudder. And I don't know if you can make it out here, but with respiration, you'll see that the septum swings from side to side. And so that's indicative of ventricular interdependence, but she doesn't have any of the other features that we normally see in a patient with HFpEF. The myocardium's not thick, there's no valvular disease. And with this ventricular interdependence, we'd often think of pericardial constriction, which she doesn't have. And so we diagnosed her with obesity HFpEF. And that's a syndrome that I'll talk about in a minute. And the treatment was diuretics, which she was already on very high dose diuretics for pulmonary hypertension, calorie restriction, SGLT2 inhibitor for marginal benefit, but about a 1.5 kilo weight loss in trials. And I did want to highlight semaglutide because semaglutide has just received approval for weight loss. It's not yet available in Canada under that formulation, which they're calling Wegovy. But I started her on therapy with the diabetes dosing at very high dosing, but using that formulation. And I think with good reason. So this was published in the New England Journal of Medicine in last year. This is the step 1 trial. And this is the seminal trial that established semaglutide for weight loss. So they enrolled patients who had a BMI of greater than 30 and no diabetes, or a BMI of greater than 27 with or a complication of obesity. And it was a 2-to-1 randomization. So there are 1,300 patients who were titrated up to semaglutide 2.4 milligrams sub-Q weekly versus placebo. And at the end of 68 weeks, there was a staggering 15.3 kilogram weight loss in the treatment arm versus 2.4 kilograms of weight loss in the placebo arm. Now, in her case, it's not just cosmetic. It's not just so she could feel better with weight loss. I'll just take you back here. The purpose of this was to reduce her weight, to offload the left heart so that she could continue in the drug trial. Perhaps more importantly, for pulmonary transplantation or lung transplantation, our cutoff is a BMI of 35, and that's a hard cutoff. So if we could get her weight below 35, then she could go on to get a lung transplant, and that would be the gold standard therapy for her idiopathic PAH. So the learning point, oh, sorry, I've got the wrong text here, but the learning point is to consider obesity HFpEF, particularly in patients who have heart failure with preserved ejection fraction, obesity, and a normal BNP. And we're learning a lot more about this pathology, but these are some of the causes and how obesity can result in HFpEF. So number one, with obesity, you have a much greater plasma volume. And so the heart is actually volume loaded. Very importantly, oh, hang on, sorry. Very importantly is that with obesity, because you have chest wall restriction, but also adiposity around the heart, so you have pericardial fat, you actually have enhanced pericardial restraint of the heart. So it's in a way like constriction, but the pericardium isn't constricted, it's just squeezing the heart. And if you think about it, that's why a patient can have elevated pressures inside of the heart, but because they're countered by this extrinsic pressure outside of the heart's actually not stretching, so the BNP is normal. We also see more ventricular remodeling and altered right ventricular and pulmonary artery hemodynamics and coupling, and they have a huge overlap with obstructive sleep apnea, as Nakul highlighted a case there. And this is really tough to diagnose. It's tough because body mass index doesn't always predict the amount of pericardial or visceral fat, and it's really that visceral or pericardial fat that leads to restraint and causes this pathology. It's also hard because dyspnea and edema are extremely common in obese individuals independent of heart failure. And we've probably all been guilty of missing a few of these cases and attributing it to deconditioning. This flies under most people's radar because natriuretic peptides, BNP or NT-proBNP, are often normal or should be normal. And then lastly, the echocardiographic examination is really tough in these patients just due to technical limitations with obesity. So that's the first case, obesity HFpEF. The second case is a 62-year-old male who comes in with 6 months of classical heart failure symptoms, including dyspnea and mild leg swelling. They have a normal blood pressure, elevated filling pressures, an elevated BNP, and a mildly elevated troponin. And we see this all the time in heart failure, and it's indicative of just low-grade myocardial injury or apoptosis. It's not a coronary syndrome. And this is the echo here. So on the left, you'll see a parasternal long axis view of the heart. And I'll just walk through this with you guys. So the myocardium appears quite thick and the cavity is small, but the left ventricular systolic function is normal. And you see that on the right side as well. This is parasternal short axis view of the heart. And here again, I'll just show some other features. So again, very thick myocardium here, and there's sort of a heterogeneous pattern throughout it. It's tough to make out, but there's mild thickening of the valves. There's a thickened interatrial septum here that shows, I think, quite nicely. And then on the left of the screen here, you can see the right ventricle is a little bit hypertrophied. And the other thing you'll notice is that the base of the heart, this side's kind of moving left to right, but the lateral wall here is really basically stuck down. And this is classic for an infiltrative restrictive cardiomyopathy. And so this patient, this is the echo report that comes back, and I included this because this is what you might see when you send a patient for HFpEF, and I think it's good for us to just pick up on some of the subtleties. So the echo is reported as normal LV size, severe concentric LVH, normal systolic function, grade 3 diastolic dysfunction. And on the right side, the size is normal. It's a bit of right ventricular hypertrophy, but the function's normal. So we see this all the time. You see left ventricular hypertrophy all the time on echo reports, but you have to be suspicious if they don't have common causes of LVH. And so for most of us, that's going to be hypertension, and that's going to be aortic stenosis. So if you look on the echo report, there's normal blood pressure. Maybe they're hypertensive and treated or don't have hypertension at all. And there's no aortic stenosis, but they have significant left ventricular hypertrophy. You should really be suspicious and perhaps work them up or refer on. And so this is a case of AL cardiac amyloidosis. It's not something you want to miss. And again, you'd consider, this is sort of the prototypical infiltrative restrictive cardiomyopathy. And so definitely consider this in patients who have LVH without a common cause, as mentioned, hypertension or aortic stenosis. Now, so those are the two cases that I wanted to highlight, and I just wanted to circle back in terms of the diagnosis. So this was the HFpEF score was developed by Yogesh Reddy, who's kind of a guru in HFpEF. And, you know, this is really meant to help rule in or help predict identify patients who are at very high risk of HFpEF. And so it's just a clinical score that goes through common variables that are predictive. So heavy, body mass index greater than 30, hypertensive, atrial fibrillation, pulmonary hypertension, elderly, and then F is for filling pressures or diastolic dysfunction by echo. And so none of these come as a surprise. And personally, I don't actually find this tool that useful to diagnose HFpEF. But I would encourage you just to consider this when you see a patient with HFpEF, and kind of consider the reverse of this score. So if you have a patient who has HFpEF, but you're not seeing features, these are typical causes of HFpEF, then I'd like for us to consider some of the more uncommon causes. And we just went over 2 of those. And sometimes those are really the ones that you don't want to miss. So look up the HFpEF score, consider it as a trigger actually to work up in particular the infiltrative restrictive cardiomyopathies. Okay, with that, I'd love to just open it up to any questions. And if something comes up and you have a question later on, feel free to email me. It's omid@summitcardiology.ca.
Perfect. Thanks, Omid. That was great. There were a few questions in the chat, so I'll just get through those. In regards to your first case, I guess they really wanted you to talk about tissue Doppler and whether there was any correlation, in particular, I guess, the obese HFpEF population, if there's any tissue Doppler features of that.
Yeah, that's a great question. That's a sort of an echo question. I think when you're seeing features of pericardial restraint, as we had pretty clearly in that echo, the differential in a patient like this would be obesity, HFpEF, or constrictive pericarditis. And pericardial constriction versus restraint is pretty easily diagnosed with, assuming you have a diffuse constrictive etiology with the lateral annulus. So the lateral annulus of the heart should be restricted, and it's kind of adherent to the pericardium. And that's one of the classical findings that we just see in pericardial restriction in general. So it's helpful to know what the differential is. Again, constriction in this case, and then you're really looking for normal tissue Dopplers, particularly on the lateral wall.
Right. Perfect. Thanks. Another question, I think, was Kristin talking about, given how difficult it is to diagnose HFpEF in obesity, should we have a low threshold to do right heart cath in these patients?
Yes.
Okay, that's good to know.
It was kind of a leading question.
Yeah, and I guess the real question, the backup question would be, and how should that be organized, particularly for the audience that we see here? They think somebody has obese HFpEF. Who do they send them to? One of the heart failure docs to kind of help organize that, or where are the right heart caths being done currently?
Well, that's a very good question, Sandeep. It is, I must just say, extremely difficult to get a diagnostic, an isolated right heart cath, just because lab time is so precious. We have one cath lab that serves all of southern Alberta. So I think access to that is difficult and probably should be triaged, if you will. And for some of these challenging cases, myself and I'm sure my colleagues would be very happy to see these patients in consultation.
Perfect, thanks. I'm gonna, in the interest of time, move on to Kristin and have her talk. And I see Yusuf did have another question, but maybe you can answer that after Kristin's talk if there's time. Perfect. I think Omid, you have to stop sharing.
I was actually, I think, able to kick him off.
Oh, good. Perfect.
Can you see my screen?
Yes.
Okay, let me just make this bigger. Just while this comes up, I will comment, actually. I thought that was a very good talk by Omid, and I actually literally in clinic just earlier this week had a patient who had been short of breath for quite some time, and they were a larger individual, and eventually had a right heart cath because there was a question of pulmonary hypertension and clearly had elevated left heart filling pressures, but a low BNP and very hard to diagnose. So thank you, Omid, for that talk. So I'll finish with guideline-directed medical therapy and hyperkalemia and heart failure. Oh. I have no disclosures that are relevant to this talk. So my case, I just have one, is a 69-year-old male who I've followed for quite some time now. He has quite extensive coronary disease with recurrent myocardial infarctions. In the early 90s, he had a CABG and LV aneurysm resection, and that was performed in England. He then, when he was visiting his home country in Pakistan, had another STEMI and had extensive stenting. And has significant residual disease. He has an ischemic cardiomyopathy with an EF of about 28%. And on previous MRIs has evidence of LAD territory infarct and even laminated thrombus. And that's been very long-standing. He has a non-specific interventricular conduction delay. Despite the extent and how long he's had his cardiomyopathy, he's NYHA class 2 at worst. And it's hard to get symptoms out of him. He walks every day and he's really accommodated to that well, considering. He also has chronic kidney disease, has had a previous biopsy. This is felt to be on the basis of ischemic nephropathy with a low EGFR, and has very long-standing hyperkalemia, requiring intermittent dosing of ACE inhibitor and ARBs, or I should say intermittent discontinuation of those therapies. So his current medications include very low-dose candesartan, carvedilol, isosorbate mononitrate, which he's on for an angina indication, which has been helpful for him. Aspirin, and I had elected to keep him on long-term clopidogrel, not evidence-based, but I've done that for the extent of his coronary disease, rosuvastatin, and empagliflozin. When he's examined, every time he comes to clinic, his blood pressure is in the range of 100 millimeters of mercury systolic, his heart rate 65, his lungs are clear, he has no signs of volume overload on exam, and he's reasonably well perfused. His labs, so his creatinine's 170, sodium 143, potassium 5.8 with a normal bicarb. And despite the extent of his cardiac disease and his renal dysfunction, his NT-proBNP is only 356. And his albumin to creatinine ratio is elevated. Here's his ECG. For the sake of time, he has a sinus rhythm with a non-specific interventricular conduction delay, as I described, and does have an LV aneurysm, and that explains the ST elevation you see. So what can be done to optimize this patient's guideline-directed medical therapy? This is a slide right out of the most recent heart failure guidelines. So certainly things that I think should be considered is switching his low-dose ARB to an ARNI. I will tell you right now with that BNP, he will not get covered. He has not been hospitalized. And if you haven't been hospitalized, you need an NT-proBNP over 600. So he was not a candidate for that and couldn't afford it. He was also quite nervous to try ARNIs with his history of hyperkalemia. Similarly, in MRA, I was somewhat nervous to trial this right up front, and it would be a contraindication with his potassium. When I initially met him, he did not have a device, if we move down to the bottom here. But in the years I've met him, he has ended up with an ICD. He is not a candidate, or at least does not have a class 1 indication for a CRT, as his QRS duration is not over 150. And that's what you would want it to be if he has a non-left bundle branch block. And even then, the evidence for a CRT is weak. So what about the hyperkalemia? So this has been an ongoing issue for this gentleman. So these are slides right out of the 2017 CCS heart failure guidelines. They recommend that if hyperkalemia is only mildly elevated, i.e. between 5 to 5.5, unless the potassium has suddenly increased, there's no need to change RAS inhibition, and that would include ACE inhibitor, ARB, ARNI, or an aldosterone antagonist. Potassium restriction in what they're taking should be reinforced, and any other sources of potassium that they might be taking inadvertently should be discontinued. If their potassium hangs out there, you can just recheck potassium as you usually would. However, if a RAS agent had recently been stopped and the potassium's on its way down, you want to recheck it in about 3 days. And in general, when the potassium's this low, you don't have to worry about stopping the agents that could be causing that from a guideline-directed medical therapy perspective. But if a RAS agent has been stopped and that potassium is on its way down, you'd want to restart it when the potassium's less than 5. So what about with more significant hyperkalemia in the range of 5.6 to 5.9? The Canadian guidelines would suggest you can continue all the RAS blockade the patient's on. That again is ARNIs, ACE inhibitors, ARBs, or aldosterone antagonists. But do that at half the previous dose. And then the other things, making sure they're not intaking inadvertently too much potassium. If their potassium is in this range, ideally their potassium and renal function should be rechecked within 72 hours. With our current environment, and getting access to lab tests can be difficult. And if when it's rechecked, the potassium remains quite elevated, one RAS agent should be stopped and the potassium should be checked again. And if the potassium remains quite elevated, above 5.5, consider a calcium or sodium polystyrene, which I will talk about further. And then again, just like before, you can consider restarting agents when the potassium gets below 5. And then lastly, if the potassium is very, very elevated, these patients should really be seen for an urgent ECG and go to the emergency room, especially if their potassium was either only minorly elevated or normal prior. Potassium should be rechecked quite quickly, and again after 72 hours, and depending on how high the repeat is, those patients will be treated appropriately in the emergency room. Agents can be restarted when serum potassium again decreased to less than 5. I will tell you anecdotally, I've had patients in my clinic whose potassiums come back at 5.8, 5.9, and if I've been lucky enough to get their potassium checked quite often, it is lower than it was previously. So do be aware there's other causes of high potassium that look high on the lab work, such as hemolysis, and look for that on the results, because often it'll even say the sample was hemolyzed, and that certainly could lead to a high potassium. High potassium foods, very important to tell patients what foods they should avoid, or at least ask them to look it up, because everyone thinks of bananas and they stop there. So here's a list just from the internet of various high potassium foods. And I think there's things on here we all don't necessarily think of. The salt substitute is an important one, or we tell our patients not to use salt, but then they use things like DASH, where the sodium is replaced by potassium. Also, if the patient has chronic kidney disease and is acidotic, the addition of sodium bicarbonate can help with hyperkalemia, as that leads to increased urinary potassium excretion. And also remember to ask about NSAIDs, because NSAIDs can increase potassium as well, particularly in patients with renal dysfunction, which many of our patients have. So aldosterone antagonists and hyperkalemia are really what I think we all think about, but of course hyperkalemia, as it was in this patient, is also exacerbated by the other agents we use. Generally, if the GFR is less than 30, the recommendation is to avoid aldosterone antagonists such as spironolactone and eplerenone. The risk of hyperkalemia with the use of these agents is higher if the patient is hypovolemic. So if you think a patient is significant hypovolemic, maybe not the best time to start these agents. When starting, please remember creatinine potassium should be repeated within 1 week and 1 month of initiation, or increase in the dose of these agents, and intermittently thereafter, usually at least every 3 months. And I find this is often missed. And again, challenges right now getting blood work quickly, i.e. within a week. And if hyperkalemia occurs and these agents are held, you can always try reinitiating it when the potassium level has dropped below 5, and giving patients education on how to reduce their other intake of potassium. So if we go back to my case, my patient was doing reasonably well, and his potassium had come down after I'd instructed him about food sources. He went to Pakistan for 6 months, and there he has cardiology and nephrology follow-up, and he returns on no ACE inhibitor or ARB, and is now on hydralazine in addition to his nitrates, and his potassium is 4.3. And he tells me that when he was away, he had recurrent hyperkalemia on his ARB, and the decision was made just to stop it. Again, his low-dose candesartan was restarted, as he did admit he wasn't following a low potassium diet, and so he had instructions to avoid a high potassium foods. But unfortunately, even with that, it was recurrently stopped over the next 2 months. And he was actually seen by another physician specialist about 2 months later when his potassium was 5.8, and he was started on daily K-Xylate. K-Xylate briefly removes potassium by exchanging sodium ions for potassium ions, and binds to a resin in the intestine. Significant complications are associated with regular use, especially of this agent, including intestinal necrosis and severe fecal impaction. And in general, it should only be considered for life-threatening hyperkalemia and if other therapies are not available. This is an old agent and it hasn't been tested in adequately powered randomized trials to assess safety, tolerability, or efficacy in the long term. So my patient comes back to the clinic about a month later after starting on Kayexalate. His potassium is better, but he's complaining of abdominal pain that he thinks is related to Kayexalate, and I agree with him. So options at this point is we can just forget it, stop the candesartan. He does have proteinuria, and so his nephrologist certainly wants him to be on it, but can it? And start hydralazine nitrate. And you could also consider if he was on a higher dose of an ARB than the very low dose he was on, you could reduce the dose. Or continue candesartan and trial another potassium lowering agent. So one such agent is Lokelma. This is a potassium binder that preferentially exchanges potassium for hydrogen and sodium. It works very quickly. You do need to avoid use in patients who've had significant constipation or bowel obstructions in the past because it exchanges potassium for sodium. It can lead to mild edema, but there's no increased heart failure hospitalization risk in trials. Each 5-gram dose contains about 400 milligrams of sodium, but how much of that actually goes in the patient is not certain. Labeling, so it is Health Canada approved for the treatment of hyperkalemia in adult patients. But CADTH, which is the Canadian Agency for Drugs and Technologies, an independent organization that helps provide informed decisions about what medications we should be using based on their efficacy and cost, actually recommends this drug should not be reimbursed by health plans because it is quite expensive. And the dosing is variable, but after a loading dose, it's anywhere from 5 grams every other day to 15 grams daily. The other new potassium binder is Valtassa or Patiramir. Valtassa is the trade name. It's a non-absorbed cation exchange polymer that increases fecal potassium excretion through binding of potassium in the lumen of the GI tract. Its onset of action, not as fast as Lokelma, so shouldn't be used for acute need to reduce the potassium. Similarly, avoid it in patients with a history of severe constipation or bowel obstruction, and it can lead to hypomagnesemia. The issue with this drug is it binds to other drugs we commonly use, including ciprofloxacin, thyroxine, or thyroid replacement, and metformin. And so you need to take it 3 hours away from those medications and can make it somewhat more cumbersome for the patient to tolerate. This drug, however, has good evidence in a New England Journal of Medicine published paper from 2015. It was studied where patients with chronic kidney disease who were receiving RAS inhibitors and who had elevated potassium levels were randomized to either patiramir or placebo after a run-in phase. It is important to note, though, the only patients who were randomized in the trial either had an adequate reduction of potassium in the run-in. Recurrence of hyperkalemia, i.e. potassium more than 5.5, occurred in 60% of the patients in the placebo group and only 15% in the patients who were able to take potassium binder. And the most common adverse event was mild to moderate constipation, and that occurred in about 11% of patients. So this drug is labeled in Canada for use of the treatment of hyperkalemia in patients with chronic kidney disease and eGFR greater than or equal to 15. And CADTH actually has suggested this medication should be reimbursed by public healthcare plans if the eGFR is greater than 15 and less than 60, and the patients are on RAS therapy. The dosing you can see is there. So this is a great paper that just actually came out in print last week. I got it at my door, but was published online in 2021 in CMAG. A nice review, but it has a really nice table in it that compares Kayexalate, Lokelma, and Valtassa. Things to point out: Kayexalate works hours to days. That's sodium polystyrene sulfonate. Sodium zirconium cyclosilicate is Lokelma. It has very quick onset, while patiramir Valtassa is 4 to 7 hours. Does it enable RAS inhibition to be used? And that's really what we're thinking about when patients have hyperkalemia, limiting our ability to get patients on RAS inhibitors. K-Xylate, not on the label and has not been shown in studies. Lokelma, not on the label, but most patients in studies of this drug were on RAS inhibitors at baseline. And actually Valtassa, it's part of the labeling because essentially all patients in studies of this drug were on RAS inhibition. The big issue is cost. So K-Xylate's cheap, it's generic. Lokelma or sodium zirconium cyclosilicate, quite expensive, anywhere from $12.50 to $25 a day and not recommended by CADTH. Whereas Valtassa still quite expensive, $13 a day, but currently has a positive CADTH recommendation. Another nice review paper that I would suggest you all look at is this paper from, I believe, 2020 from Jack, State-of-the-Art Review. In this paper, they also have a nice table that helps guide when you should be considering potassium binders to help reduce potassium in patients having difficulty tolerating RAS inhibition. So generally, if potassium is less than 5.5, you don't have to put the patient on a potassium binder unless you're concerned about their follow-up. And if they're on a potassium binder already and it's kept their potassium in that range, continue it. If their potassium is 5.5 to 5.9, look at the MRA dosing they're on. So specifically what they recommend is if the patient's on a high dose of an MRA, such as spironolactone 50, decrease that to 25, or if they're on 25, decrease it to every other day. Ideally, do not touch the ACE inhibitor, ARB or ARNI. Reassess the potassium in a week. If the level's still high, then that's when you consider adding Lokelma or Patiomir if you can access it. And if the potassium drops to less than 5.5, you can consider increasing the MRA dose back up and maintaining the potassium binder. If the potassium remains elevated, do not increase the MRA and up titrate the binder. And then lastly, if the potassium's very high, greater than 6, in general, the MRA should be reduced and stopped altogether, and the ACE inhibitor, ARB or ARNI, dropped to 50%. And then you can follow the instructions there to consider starting a potassium binder. These recommendations are a little different than what we would do according to the Canadian guidelines in terms of changing your MRA and your ACE inhibitor, ARB or ARNI, but really not a huge difference. So the issue is, how do we get access? So very few patients are on these. Some private plans will be available to pay for them. We have samples. For instance, there's Lokelma samples at the Rocky View General Hospital Heart Function Clinic. Patient may be willing to pay, and compassionate drug coverage for the company. And this is where I've had success accessing Valtassa. They have quite a good compassionate drug coverage program that I've been very successful at getting. STED, so STED is the short-term exceptional drug coverage program here in Alberta that will pay for high-cost drugs. I emailed STED prior to this talk. That program has never covered Lokelma due to its CADTH recommendation. I applied for Valtassa through that program a year ago and tried it again actually last week for a patient I had on this drug under compassionate drug coverage. And they informed me it's still under review, and that was a similar answer a year ago. So that process takes a long time. So you currently can't access that drug either. So lastly, back to the case, I started the patient on 8.4 grams daily of Valtassa, up titrated it to 16.8 grams daily for a goal potassium of 4 to 5.5, and was able to access the drug through the compassionate program. The patient has been very resistant to starting an MRA given issues with hyperkalemia previously, which I do understand. I then tried though to increase his candesartan up to 8, and his potassium remained okay, but his creatinine increased to 265 with no other cause. So I've decreased the dose back down and asked him to increase oral fluid intake, and his follow-up labs are pending. So unfortunately, he didn't tolerate the increased dose of candesartan due to an increase in creatinine, not due to an increase in potassium. And since being on Valtassa, it's the first time he's ever been able to maintain on an ARB for more than a few months. So I'll stop there and take any questions.
Thanks, Kristin. That was great. And certainly one of the banes of our existence is potassium and potassium management. And you've outlined where we have ability and where we're still struggling. So thank you very much for that. It was a great talk. There was one comment and one question. in the chat. One was a comment about no salt is the salt substitute, not Mrs. Dash. That's the comment.
Fair enough. Fair enough.
And I don't know enough about this, but I would say that they're probably right. And the question really was in regards to eplerenone and the risk of hyperkalemia. Is it the same, and I'm presuming, as other MRAs like spironolactone?
You know, to my knowledge, there hasn't been a trial that's compared spironolactone to eplerenone. I'd have to go back and look at the trials to really tell you for sure. But certainly the recommendations around how you monitor eplerenone are the same as spironolactone. And I've definitely seen patients become hyperkalemic on eplerenone. So my sense is they're very similar, but I just don't know the exact numbers from the trials off the top of my head. But I would treat them the same when it comes to the risk of hyperkalemia myself.
Sure, and then Kristin, as a different question, as you know, there are some new mineralocorticoid receptor antagonists coming down the pipelines that don't cause hyperkalemia and are much better tolerated. Do you have any comments about that currently? They're under trial, as I understand it.
Yeah, they're under trials, and I don't have personal experience using them. So I think we'll need to see what the outcomes will be in heart failure patients specifically. But certainly I think, as I've shown in this case, we'll still have a large group of patients, especially those with renal dysfunction, who will have issues with hyperkalemia, even when it comes to just being on an ARB. So I don't think this problem is going to go away. Definitely, though, if those agents potentially replace our traditional spironolactone and eplerenone, it might make our lives easier from a hyperkalemia perspective, but it'll still be there.
Well, thank you. We only have a couple more minutes till 8:30, and I'm actually quite surprised. You know, almost 50 people stayed online to listen to the very, very end. We even had people who were logging on at the end. So first I want to thank all of the speakers. Everybody did a very good job, and lots of different pieces of information coming at us. I will remind people, if they want to review it, we're going to be posting this to the Libin YouTube channel, which I encourage you to visit because there's lots of good information there. And the other heart failure talks that we've done, the new era in heart failure, are also posted there. And so I'd like to thank everybody for sticking around till the very end. And I don't know if any of my presenters have any final words, but
Sandeep, I'd like to share one thing to everyone. In being able to do prompt follow-up, I'm not sure if everyone's aware of the pilot project right now with Alberta Precision Labs in being able to order time-sensitive blood work. But you can go to the APL website, click on healthcare providers, click on time-sensitive labs, and you can get labs in 5, 6 days, 7 days, between that and 21 days. And you put in the patient's email and phone number, and they're sent the appointment directly, and it is prompt and effective. That's all.
And that's very important for our heart function clinic patients that do need that assessment a little bit quicker. You know, we know that there's an issue with lab tubes right now, but you know, in our patients who actually do need it in a timely fashion to address either potassium or kidney function, sodium, whatever, I think that that's an important message to try to get these lab tests done in the time frame that you need, because it's really frustrating to tell a patient, hey, get your lab done in a week, and then leaving it up to them to figure it out. So thanks for adding that piece of information. And with that, I'm going to call it a night. Thank you, everybody, and we will see you next time.
Good night.
Good night.
Good night. Thank you.